the more important and exciting presentations that we have to offer. It's an update on therapeutics for COVID-19. The last time we talked about this topic with Natasha Chida was over 3 months ago, and so much has changed. Hydroxychloroquine came in vogue and out of vogue. Remdesivir fell and soared and fell again, and I don't know where we're at actually. I'm looking forward to Chris telling me what's the latest. And I think we have a lot more understanding about which patient populations certain therapeutics work in. So without further ado, I want to get us started. House rules as normal. If you could mute yourself and mute your video, that would be great. Use the chat function to introduce yourself. We're coming to the end of our seminar series, so it is really important for each of you to be able to connect with other individuals that are in your countries or in your areas of expertise that you can share knowledge with, resources, and collaborate with. The Q&A box is what we're going to be using, questions and answers, and we'll take them right at the end. Hopefully we'll have like a 30-minute presentation and then plenty of time for Q&A for our expert. So I'm going to introduce our expert, Dr. Chris Hoffmann, who is one of my mentors and collaborators and has been as an associate professor in the Department of Infectious Diseases at Johns Hopkins University. He's also the lead author for the system-wide COVID-19 guidance on therapeutics at Johns Hopkins. So we couldn't ask for a better person to talk us through all of the data that's sitting out there. I'm going to hand over to Chris, and I will see you towards the end of the talk.
Thanks so much, Bhakti. It's hard to live up to that introduction, but I will hopefully provide some useful information. If I can get my slides to advance, great. So as Bhakti said, I'll be updating on COVID-19 therapeutics and prophylaxis. Now there's a huge amount that could be discussed, and hours could be spent discussing currently available therapeutics and prophylaxis and what is under research in the future. I'm going to focus just on what is either currently available globally or at least in limited settings, what is currently available, and really focusing on clinical trial data to support use or to suggest that use is not appropriate for certain agents. So by way of outline, I'll be talking first about therapeutics and timing of use, where they may be most useful, supportive and adjunctive care, antiviral therapies, immune-based therapies, prophylaxis, and then I'll try to wrap it all up in a summary. So first, in terms of the timing of use of therapeutics, first, there are individuals who are at risk for SARS-CoV-2 infection or COVID disease, which is pretty much all of us all around the world. And for us who are at risk, there's certain agents that may be of value. Then there's a second group of people who are exposed and have developed infection or exposed and have not yet developed an infection, and they can be considered. And then finally, there are individuals who've developed COVID-19, that is symptoms, early symptoms, fevers, cough, myalgia, dyspnea, ageusia, anosmia, etc. After about a week or in the second week, some patients progress to worsening symptoms, including hypoxic respiratory failure, sometimes with high fevers and hypotension. This is sometimes characterized by a hyperimmune state or a cytokine release type syndrome. And then finally, some patients progress to ARDS phenotype. What I've shown in the red line is viremia, or at least viremia as approximated by levels of SARS-CoV-2 RNA in upper airways. And you can see that it's believed that viremia peaks either prior to symptom onset or in early in the symptomatic period, and then actually rapidly declines during the first week of symptoms. This is critical to keep in mind in considering when specific therapeutic agents may be of most use. So first, those individuals who are at risk, they do not have infection at the time of use of any of these agents. Vaccines, immunoglobulins, and convalescent plasma all may have an important role. Certainly I and probably everyone on this call has great hope for vaccines, and that's certainly what will be needed, I believe, to fully control the pandemic. Individuals who are exposed and either have developed actual infection but are preclinical or asymptomatic or may not have developed infection may benefit from specific antivirals or convalescent plasma, and I'll discuss both of those in a little more detail. And then finally, individuals with COVID, and specifically individuals hospitalized with COVID. Much of this presentation will really focus on the hospitalized patient, may benefit early in the disease course from antivirals. However, as symptoms progress and as the disease progresses, viremia is believed to decline markedly, and the place and value of an antiviral is likely to be minimal. Similarly, with convalescent plasma, it's likely to be most useful very early in the disease course, with diminishing value as the disease progresses. On the other hand, immunomodulators may have their biggest role prior to or during the cytokine hyperstimulation phase. And then adjuvantive therapy may have a role throughout the disease course in hospitalized patients. So I'm going to jump right to supportive and adjunctive care. First, probably the most important tools that we currently have for management of people with COVID-19 in the hospital are good nursing care, monitoring of oxygen saturation, supplemental oxygenation when needed, and mechanical ventilation also when indicated. There's considerable hospital to hospital and location to location variation in outcomes with COVID-19. Some is certainly related to the patient population, but some is likely related to the level of care that's provided. I'll go on now to adjunctive therapies and specifically just to anticoagulation. So COVID-19 disease is associated with a hypercoagulable state. Many infections are, but for COVID-19, it's really more marked than most other infections. And COVID-19 leads to endothelial injury through direct viral action and or cytokine-mediated pathophysiology. Also leads to stasis, just that people are more likely to be immobile or bedridden. And then it also leads to a marked hypercoagulability state, much more so than most other infections, which is indicated by an increase in von Willebrand factor, D-dimer, and fibrinogen. Because of this hypercoagulable state, VTE is very common among hospitalized patients with COVID-19. In a systematic review and meta-analysis, 13% of ward patients on VTE prophylaxis developed a PE or DVT, and 30% of ICU patients on VTE prophylaxis developed a PE or DVT. And in some of the retrospective reports, over 2/3 of patients in an ICU on VTE prophylaxis developed a PE or DVT. So managing and trying to prevent VTE is certainly a cornerstone of COVID-19 management. However, at present it is unclear what is most appropriate. Standard VTE prophylaxis has the advantage of a long history of safety, but clearly breakthrough. Higher dose VTE prophylaxis may be appropriate and is used in intensive care units at Johns Hopkins. And then some have advocated for therapeutic anticoagulation for people with COVID-19 disease to prevent VTE. Further information is certainly needed from clinical trials to determine which of these is the most appropriate, but some anticoagulation certainly is a component of therapies for COVID-19. I'm going to move on to antiviral therapies now. So back to the slide. Again, I just want to emphasize that antivirals likely have their biggest role among people who are exposed and either not yet viremic or early preclinical stage, and as does convalescent plasma, or they have a role early in the disease in hospitalized patients. But that role is likely to diminish. And it's important to keep that in mind in evaluating results from clinical trials and interpreting those results and whether there was a benefit or not. I'm just going to talk about 4 antiviral therapies: Remdesivir, Hydroxychloroquine, lopinavir/ritonavir, and convalescent plasma. There are many others that have been studied, some that clinical trials have been published, and even more that are currently under study. None of the others are in general use, at least in the United States, and none of the others have clear, robust evidence of effectiveness, which is why I've limited it to these 4 agents. Starting with Remdesivir, this is an inhibitor of the viral nucleoside RDRP. It is an IV medication. There's a loading dose of 200 milligrams, followed by a daily dose of 100 milligrams for either 5 or 10 days. In the United States, there's an FDA expanded access approval, and within that approval, eligibility is specified as adults and children with an oxygen saturation of 94% or less on room air, or who require mechanical ventilation or ECMO. And the main contraindication is a ALT greater than 5 times the upper limit of normal. It's although there's a lack of human data in pregnancy, it is used in pregnancy. The first published RCT on Remdesivir was from China, double-blind RCT of 237 participants, randomized 2-to-1 to Remdesivir and placebo. The time from symptom onset to treatment was a median of 10 days, with a fairly narrow interquartile range of 9 to 12. I'll be mentioning this for basically all the studies because of the critical timing for different agents for effectiveness. The primary outcome was clinical improvement, and in final results, there was no difference in that primary outcome between Remdesivir and placebo. Deaths were a secondary outcome and were also similar between Remdesivir and placebo. Similarly, time to negative viral RNA was similar between these 2 groups. Subgroup analyses, which need to be taken with a grain of salt to some degree, but can lead to some hypothesis generation, were performed in this study, and the subgroup analysis among patients with less than 10 days of symptoms suggested faster clinical improvement among those in the Remdesivir arm. The ACT-1 study is a study that was performed in the United States. 1,000 participants were randomized 1-to-1 to Remdesivir or placebo. Similar to the study performed in China, 10 days of Remdesivir were used. The timing of treatment initiation from symptom onset was 9 days with an interquartile range of 6 to 12. So some patients, or a quarter of patients, had less than 6 days of symptoms. And the primary outcome was a time to recovery based on a 8-category scale. And there was a more rapid time to recovery in the Remdesivir arm, 11 days compared to 15 in the placebo, which was statistically significant. There was also an indication of lower mortality among participants who received Remdesivir compared to placebo, with 8% dying in the Remdesivir arm and 11 in the placebo arm, although this did not reach statistical significance based on a p-value of less than 0.05. I will note that whether or not mortality was reduced with Remdesivir, 8% mortality is still high, and suggests that while Remdesivir has suggestions of being helpful, certainly is not a cure or a panacea for COVID-19. In subgroup analysis, again with caveats that subgroup analyses sometimes need to be taken with a grain of salt, there was improvement among patients with supplemental oxygen, non-invasive or non-ventilated patients, but no difference among patients with ventilation, non-invasive or invasive mechanical ventilation. It was not reported whether this was also collinear with a shorter time of symptoms, which may be the case, or whether there was some fundamental pathophysiology making remdesivir less effective in patients with more serious oxygen requirements. The third remdesivir trial I wanted to mention was a trial done by the manufacturer Gilead. It was an open-label RCT of 397 participants randomized 1-to-1 to 10 or 5 days of remdesivir. Enrollment criteria were similar to the two previous trials, SARS-CoV-2 pneumonia with an oxygen saturation of less than or equal to 94%. And in an open-label manner, those two durations of therapy were compared. In this study, there was no difference in the median duration of symptoms, in the median duration of symptoms between arms, or in clinical improvement or death. There were more serious AEs in the 10 days of remdesivir. This study certainly suggests that 5 days of remdesivir are likely sufficient if remdesivir has a therapeutic value, and that there is unlikely to be a general value of a longer duration of remdesivir use. At the Johns Hopkins Health System, we generally use 5 days in order to maximize supply and limit it to people who are SARS-CoV-2 positive, have an ALT less than 5 times the upper limit of normal, and prioritize patients receiving supplemental oxygen via nasal cannula over those without supplemental oxygen need or receiving ventilation, and prioritize it for patients who have been hospitalized for less than 10 days. I'm going to move on to hydroxychloroquine, certainly the most controversial and agent that has received the most lay press and also scientific preprints and publications. Hydroxychloroquine is hypothesized to inhibit viral fusion through changing pH in the endosome. It's been widely used worldwide and continues to be used in some settings. And there have been multiple studies reported in press releases, preprint, and peer-reviewed literature. Many of them have been retrospective. Most of the retrospective studies have reported no benefit from hydroxychloroquine. Some have reported an improvement in clinical outcomes, and some have reported clinical harm. Fortunately, we have prospective randomized controlled trials, both open label and placebo controlled. The first published open label RCT of hydroxychloroquine involved 150 participants randomized 1-to-1 to hydroxychloroquine or standard care. And the time from symptom onset to treatment initiation was a median of 16 days. So for an antiviral effect, it is unlikely, based on a hypothesis that viremia peaks early in the disease course, that there would be any significant benefit found. And indeed, in this study, time to or clinical improvement at 28 days was similar between arms, as was negative viral RNA on day 28. Another study came from the United Kingdom, part of the recovery trial, which is a multi-arm open label RCT performed in multiple hospitals in the UK. In this arm, 1,500 patients were randomized to hydroxychloroquine and 3,000 to standard of care. Time from symptom onset to treatment was 9 days, with a quarter of patients less than 5 days of symptoms. So certainly in the range that we had hypothesized that an antiviral could have therapeutic benefit. And the primary outcome was being discharged alive at 28 days. And in this study, there was no significant difference. Perhaps you could say that standard of care was favored, with 62.8% discharged alive at 28 days in the standard of care, compared to 60% in hydroxychloroquine. In a composite outcome of mechanical ventilation or death, again, there was not a significant difference. In subgroup analysis looking at individuals with symptoms of 7 or less days versus more than 7 days, again, there was no difference in outcomes. So taken together, these two trials certainly I think indicate that there is not a therapeutic role for hydroxychloroquine in the management of COVID-19 in hospitalized patients. I'm going to move on to lopinavir-ritonavir. Again, the recovery trial, this multi-arm open label trial in the UK. This is just from a press release, so information is a little more scanty than some of the other data that I'm presenting. But 1,500 patients were in the lopinavir arm and 3,000 in the usual care arm. And they reported no difference in 28-day mortality, mechanical ventilation, or length of stay by arm. Another lopinavir-ritonavir study comes from China. In this open label RCT, 199 participants were randomized 1-to-1 to lopinavir versus standard of care. Time from symptom onset to treatment was 13 days, so a bit longer than in the recovery study. And clinical improvement was the primary outcome. And in this study, again, there was no difference in arms in terms of clinical improvement. Mortality at 28 days was non-significantly different, although slightly higher mortality in the standard of care. And negative viral RNA on day 28 was similar in the two arms. Taken together, these two studies also should dampen enthusiasm for lopinavir, and it's certainly unlikely that lopinavir has a role in managing COVID-19 for hospitalized patients. I'm going to move on to convalescent plasma now. So convalescent plasma has been around longer than any of these antivirals, or really longer than pharmacologic antiviral therapy. The rationale is that it provides passive antibody therapy and may be used to either prevent infection or change the disease course prior to a patient developing their own endogenous neutralizing antibodies. And there's a long history of successful use for other infectious diseases, either for treatment or prevention. Because it depends on neutralizing antibody, the neutralizing antibody titer of the unit that is used or transfused is critical to its success. And really, units should be titered prior to use to assure appropriate neutralizing antibody levels. In terms of overall convalescent plasma, about a third or 2/3, depending on the population, may lack sufficient neutralizing antibodies to be considered potentially effective, if effective, for managing COVID-19. Because it works by passive transfer of neutralizing antibodies, it's most likely to work before a patient has developed his or her own endogenous neutralizing antibodies. So likely early in the infection, maybe in the first week of infection. Before getting into any results of effectiveness, I wanted to mention a recent publication analyzing 21,000 patients who had received convalescent plasma in the United States. And in that study, they reported safety, and less than 1% of participants had any transfusion-related events, with 0.1% developing transfusion-associated lung injury. So what are the data to support or refute the use of convalescent plasma? So there have been 2 randomized controlled trials published. One completed in China. 103 participants were enrolled. The study was stopped early due to no additional patients in the study area before they accrued the intended 200 participants. The time from symptom onset to treatment was a median of 30 days. So it's unlikely, based on the hypothesized mechanism of action, that this agent would have helped the patients who received it. And there was no difference in clinical improvement by arm. The other RCT was performed in the Netherlands. 86 participants were recruited and randomized, and it was stopped early due to futility. The time from symptoms to treatment was a median of 9 days, so much shorter, but still a time period that endogenous neutralizing antibodies may have been present. And indeed, in this study, they tested the participants for neutralizing antibodies, and the majority of participants had neutralizing antibodies at the time of treatment. So really, probably a period where convalescent plasma would have limited value. And there was no difference in mortality, hospital stay, or day 15 disease severity between arms in this study. There are more data that are supportive that come from retrospective reviews. However, given the difficulty even with statistical management of the data, of really having appropriate comparison, it is really hard to know how effective convalescent plasma may be at reducing symptoms and improving outcomes for people hospitalized with COVID-19. I think this is a space that needs to be closely watched. I think there's certainly hope that convalescent plasma may have a role, and it continues to be widely used, including at Johns Hopkins. I'm going to move on to immune-based therapy. Again, the slide with the disease course and timing of use. And for immune-based therapy, certainly immune modulators that affect cytokine release and cytokine hyperstimulation, it is likely that the most benefit will be during a period when there's a cytokine release syndrome type phenotype, which generally is during the second week of disease. I'll just speak about corticosteroids and targeted immune therapies with IL-6 receptor inhibitors. Going to the recovery trial again, that multi-arm open-label trial in the UK, they looked at dexamethasone there in one of the arms. Dexamethasone may have been chosen due to advantages in critical illness in that it leads to less fluid retention than other steroids due to less mineral allocorticoid activity. Recovery randomized 2,000 participants to dexamethasone and 4,000 to standard of care. And the time from symptom onset to treatment was a median of 8 days with an interquartile range of 5 to 13. And in the overall analysis, there was lower mortality among participants who received dexamethasone, 21% compared to 24% in standard of care. And in subgroup analyses, specific groups had a greater benefit. For example, patients who received invasive ventilation had quite a marked reduction in mortality from 40% in the standard of care arm down to 29% in the dexamethasone arm. Patients who received supplemental oxygen, non-invasive, non-ventilatory supplemental oxygen also had an improvement in survival, 21% deaths in dexamethasone compared to 25% in the standard of care. While those who received no supplemental oxygen and were not hypoxic did not have an improvement in outcomes with dexamethasone. And there was no statistical difference between the arms, although slightly higher mortality in the dexamethasone arm. So based on this study, there's certainly a lot of enthusiasm for use of dexamethasone. The exact appropriate timing is unclear. Whether it should be used early or not, certainly unclear. But there does seem to be a role certainly for patients who require supplemental oxygen. Moving on to IL-6 receptor inhibitors. Again, possible benefit during a cytokine storm phenotype, which is indicated by a marked increase in soluble IL-6, as well as generally C-reactive protein, ferritin, and other inflammatory markers. There have been 2 small randomized clinical trials. Both of them use similar enrollment criteria, and both of the enrollment criteria were saturation of oxygen of less than 94% and pneumonia, but there were no criteria regarding indication of inflammation. One of these studies was with tocilizumab, which is a monoclonal antibody IL-6 receptor inhibitor. And in this placebo-controlled RCT of 450 patients, there was no significant difference in clinical status by arm. Another monoclonal IL-6 receptor inhibitor trial was with sirolimus, and in this study, there were 174 participants enrolled. It appears that it was stopped for futility, at least according to the press report. And again, no significant difference in clinical status by arm. I would comment on both of these studies The fact that they did not use indications of inflammation certainly limit really identifying the patient population that may benefit. And if IL-6 receptor inhibition does have a role, it would appear, at least in my mind, that it would occur when IL-6 levels are high and there's marked inflammation. I'm going to go on to prophylaxis just briefly. Again, vaccines really offer the greatest hope. Lots of vaccine trials. I won't speak more about those. Convalescent plasma certainly has a hope also. It's a little more complex, given that it needs to be transfused, and it's unclear how long a transfusion of convalescent plasma may provide prophylaxis. Antivirals also provide an important hope, and there are ongoing trials of antivirals. What has been studied is hydroxychloroquine. So I'll just review the hydroxychloroquine prophylactic studies. There's an open label RCT of 2,000 healthy contacts, randomized 1-to-1 to hydroxychloroquine versus standard care. And the primary outcome was PCR confirmed SARS-CoV-2 positivity. And in this study, there was no difference between arms. Participants who received hydroxychloroquine had 5.7% PCR positivity compared to 6.2% in the standard of care arm. Another study using hydroxychloroquine for prevention was a double-blind, placebo-controlled RCT of 821 healthy contacts receiving hydroxychloroquine versus placebo 1-to-1. And the primary outcome here was COVID-19 illness, not necessarily PCR confirmed, and 11% of those who received hydroxychloroquine versus 14% in the placebo arm developed symptoms compatible with COVID-19, which was not significantly different. So after a lot of enthusiasm early this year with hydroxychloroquine for prophylaxis, clinical trials to date have shown that it does not have a role for preventing SARS-CoV-2 infection or COVID disease. So in summary, I'm just going to talk about a treatment approach and really what is done at Hopkins, but is mostly available throughout the world. First is supportive care and appropriate oxygen monitoring and supplementation. Second is anticoagulation. We still need to know what the best anticoagulation is to reduce morbidity and mortality from COVID-19, but some anticoagulation is certainly part of the treatment. Remdesivir seems to have a role for early use and global supply. I'm not sure what it is currently, but there is licensing for generic manufacture and efforts to increase global supply of remdesivir. Convalescent plasma still need to have more clinical trial data, but there appears to be a role for early use. In addition, there are ongoing trials for convalescent plasma for post-exposure prophylaxis. Dexamethasone certainly appears to have an important role for patients receiving supplemental oxygen, either with or without ventilation. And finally, IL-6 receptor antagonists, while their cost may prevent access in many parts of the world, there certainly may be a specific patient population that has a cytokine release hyper IL-6 type phenotype that may benefit and have improved outcomes. So I wish all of you well in reducing morbidity and mortality from COVID-19. Also wish all of you remain safe and yourselves in managing patients with COVID-19. Use the necessary preventive gear, and certainly thank you for your attention. I'm certainly open and welcome to take any questions.
Thank you so much, Chris. That was really interesting. I'm also surprised that there were so many similarities from what we saw 3 months ago, and I think we had all hoped that there would be more progression in this field and with more answers, but it seems there's much work to be done. I have a couple of questions in the Q&A. I'd encourage others to also post your questions. The first one I have is, and some of these are quite specific. So given the Dutch con-COVID group noted that a lot of patients developed antibodies within 2 to 3 days of admission, does it make sense to deploy convalescent plasma as a preventative option?
Perhaps you can rephrase that, Bhakti, so I didn't,
I think what the Pranav Chatterjee is trying to say, and Pranav, feel free to raise your hand and we can get to ask it directly, but the question here is could convalescent plasma be a preventative option to prevent severity of illness in COVID-19?
Yeah, so I think prevention prior to symptom onset in patients who are exposed, I think there's certainly an important role there. The challenge is that it is a transfusion. So it's a harder to use preventive, although in the past for other infections like hepatitis A, injections of purified immunoglobulins were given. And I would say that this is likely I would agree that this is likely the most useful role, although there are certainly logistic challenges with doing it. But there is a study ongoing at Hopkins to use convalescent plasma for prophylaxis for people who are exposed.
Interesting, thank you so much. Another question from Pranav Chatterjee asks about monoclonal antibodies. So any role of more upstream acting immunomodulators such as itolizumab, which showed a small mortality benefit at a pharma-funded study in India?
Sure, yeah, so there are lots of studies of other immunomodulators besides the two that I discussed and besides IL-6 receptor inhibitors. And I think those studies, continued studies, larger studies are incredibly important. I think the two challenges are figuring out the exact timing for therapy, who is going to benefit, because patients who do not have this immune inflammation phenotype may not benefit, and then access, because many of them are very expensive products.
Thank you so much. An interesting question that probably impacts a lot of our colleagues around the world is, in countries where there's a high prevalence of TB, is the role of IL-6 inhibitors somehow threatened?
So
interplay between the two.
Sure. So in terms of IL-6 inhibitor use and other specific immune activating agents that are used, for example, in rheumatologic diseases, screening for active or latent TB infection is important prior to use. Whether a single dose of tocilizumab will lead to reactivation of TB is unclear, but certainly something that patients who receive it in TB endemic areas probably should have somewhat closer follow-up. Whether they should have any different management, at this point, certainly there's not enough data to say. And just data from long-term use of these agents would suggest an increased risk of TB, but that risk tends to occur after more than a single dose.
Thank you so much, Chris. Sounds like a good research project for somebody to do. I have a couple of questions that I was just asking for your thoughts. Any thoughts on antagonists of endothelial 1? Where do monoclonal antibodies and interferon beta potentially fit in? Any words
yeah, lots of questions. So first, interferon beta. I was going to discuss it and then I dropped it. I think it should be studied more. There are some ongoing studies. There was a study from, and I know it's widely used in Hong Kong, or has been. There was a study from, I believe, Hong Kong or mainland China that included it in, along with lopinavir and arabinol, I believe. And that did suggest that there was an improvement. It was a complicated study and a little difficult to untangle whether it was the interferon beta that had the effect. I would argue it was, and I think it certainly is an agent for consideration. And for people who have it available and are comfortable with using it, I think it's a very reasonable agent to use. It is believed that there is the concern that it could increase in an inflammatory state. So there is some hesitance to use it in patients who are developing more of an inflammatory state, but early in the disease course, it certainly may have an important role. Then you asked about some other agents, all of which are
one and monoclonal antibodies.
So all of those are in, monoclonal antibodies to various components of the inflammatory pathway certainly are under study. Monoclonal antibodies specifically to SARS-CoV-2, I'm unaware of, and then various endothelial acting agents are either in clinical trials now or in proposed clinical trials.
Thank you so much. And then Chris had mentioned to me at the start of this presentation that he had a much larger slide deck that he trimmed back. So maybe we can ask you to put in some of the interferon beta slides back in,
Sure.
so you can see some of the data that you had sorted through. A philosophical question, and I'm sure you and I will have answers to this one, but since hydroxychloroquine has been shown to not have a significant role either as a therapeutic or a prophylactic agent, why are we still using it?
Very philosophical. Well, I would say it should not be used. I mean, the do no harm is sort of what we should live by, and something that is demonstrated not to provide any benefit only has an opportunity to provide harm. However, I certainly understand high mortality, and as you saw in many of these studies, a lot of patients are dying of COVID, especially patients in the hospital or in intensive care units. So there's a feeling of wanting to do something rather than nothing. Unfortunately, I think hydroxychloroquine is not the right something.
Yeah, I agree with that completely. David Peter wants to ask you a hard question, so I'm just going to read it out for you. He's not making it easy. So he said, thank you for a great presentation. You mentioned that in the ACT-1 trial, that 8% mortality is still extremely high. It seems in both arms, the case fatality rates are lower than those shown in other non-Remdesivir trials, i.e. Those case fatality rates are around 13% to 41%. How much of a difference do you think in the case fatality rates is due to differences in the patient populations under study, say compared to the differences in the standard of care interventions?
I think it's a great question. It's a super question. It's a great question. And I don't think there's an answer. There's certainly big population differences. And some of the studies with very high mortality from the UK has simply had some of the highest mortality. And I think a lot of that is likely population differences. I hope that it's not inferior delivery of care. But I think really trying to understand some of the aspects of delivery of care is important. And it's why I started with saying that the supportive care, oxygenation, kind of dotting the I's and crossing the T's is really a critical part of managing people with COVID. Unfortunately, we don't know which aspects of those are most critical, but many of those are likely important and may play some role. But I tend to think the population is really important. And part of the population may not just be characteristics like age or comorbidities, but the time that they actually present to for health care. And late presentation should ways to get people to be not afraid to come into the health system or hospital when they need the hospital is part of what's needed to reduce mortality, I believe.
And just to echo that, we've seen huge variances in the US between mortality across different settings. from mortality reported as high as over 60% to numbers as low as 23% in patients who are on ECMO. So I think, you know, variance in practice and variance in standard of care interventions, resources do have a significant impact. And I would assume that those are enrolled in a well-constructed clinical trial probably have more resource availability at those facilities. Last but not least, we have one more question on Remdesivir. So would you give Remdesivir according to a patient's comorbidities, or would you focus the treatment just in the inpatient setting?
So since Remdesivir is an IV medication, it makes it a little harder to do in the outpatient setting for a daily IV infusion. I think certainly in a patient who had diagnosed COVID and had high factors associated with higher morbidity and mortality, like advanced age or specific comorbidities, I think using an antiviral in the pre-hospital setting would be great. And if there is access to Remdesivir and the setup to provide that IV infusion, it would seem appropriate. There are other antivirals in clinical trials now that are oral, and for general use in terms of non-hospitalized patients with less severe COVID, I think it would be terrific to use those to prevent progression to more severe disease.
Thank you so much. One last question. Is BCG completely written off, or is that a therapeutic option that's still being pursued?
So I know there were some clinical trials that were being proposed or initiated. I do not know what the status of those studies are. I think some of the ecological basis that BCG was based on now as the pandemic has spread more widely are no longer as well supported. But BCG certainly appears to reduce mortality among children beyond simply from reduced TB. Whether there's a role for BCG, I really don't know though. I think it's a fascinating hypothesis, and it would be interesting if any of the studies that were planned were executed and we have some results.
Thank you so much, Chris. That was an extremely concise and eye-opening talk, and it really, I think, cleared up a lot of the myths or the questions that we're facing, especially with the infodemic that COVID-19 has also brought onto us. Is there therapeutics guidance that has been produced by Hopkins broadly available for sharing?
Sure. Sure. The therapeutics guidance document is certainly can be shared. I know there's an internal location, internal Hopkins, but it doesn't mean that it can't be shared. It's not a confidential document.
Okay, great. So what we'll do is we'll download that from our intranet and make sure it's put onto our website. You'll also see a recording of the talk in the next 24 hours, including a PDF of the PowerPoint slides. Next week, we're going to talk about the maternal and pediatric considerations of COVID-19. There's been several new studies that have been showing the impact of COVID-19 on children in particular. We're coming to the end of our seminar series, people. So we're talking about considering a COVID-19 and beyond series. So if you have suggestions and ideas, then please let us know, and we will try and incorporate them. The last thing I was going to tell you is that we are planning on creating a one-site, one-page resources from all of our speakers. So hopefully that'll be available to you shortly. If you have resources or guidance, job aids that are at the country level that you've been working on that you think would benefit other countries or other institutions within a country, then please just email us, or you can email me directly, bhamsot1@jh.edu. On our webpage, we'll put a link for you to drop information in. but we would like to be able to serve as a place for knowledge and resource sharing. So thank you everybody for joining. Thank you in particular to Chris for your extremely hard work in mining through what is a mountain of data to give us some real clear take-home points. It's very, very much appreciated.
Thanks, Bhakti, and good luck to all of you.
Take care, everybody.